Shall I start? Good morning, everyone. Today's topic of discussion is artificial intelligence in orthopedic surgery. It describes about the way it works and the significance in the field of orthopedics and its utilities and how it reduces the work and eases the work of the clinicians and practitioners. So I took a journal from the Bone Joint Research, which was published in 2023 and conducted by the University College London Hospitals in UK. National Health Schemes. So to define artificial intelligence is a replication of human intellect via computers. It is becoming an integral part of modern society, and it helps in adopting a proactive health management approach expected to result in fewer hospitalizations, fewer doctor visits and reduced treatments, and early detection of disease with known cures. Artificial intelligence is showing a promise as useful tool in the healthcare research armamentarium, and algorithms based on clinical data sets for predicting patients' clinical outcomes are rigorously being explored. This concept encompasses data sets so large that there is no conceivable way that humans could comprehend such a plethora of information without the use of technology. While AI can categorize and make sense of big data, it is still only as good as the data provided, and thus human contribution is paramount. While still in its infancy, the application of AI in the field of orthopedics is a new frontier of data science. And orthopedic surgery is already home to most of the innovative technologies such as robotic assisted surgery, which I have explained a few days back, and of which AI is an ever-growing part. The purpose of this narrative review article is to provide a comprehensive understanding of AI and its subfields. In addition to delineating its role in orthopedic surgery and describing current existing applications. And coming to the artificial intelligence, it has subtypes as machine learning, deep learning, and neural networks. And it is applied for the beneficiaries of early cases of osteoarthritis and detection of them, and also in bone and soft tissue tumor detection, clinical prediction tools, example, the length of stay in the hospitals, and surgical training in the robotic surgery, arthroplasty implant loosening prediction, and meniscal damage diagnosis, fracture recognition and classification, precision medicine, example including the gene level analysis, knee hip arthroplasty, implant identification, which is, in this case, it is patient specific. There is no such generalized, no need of generalized implants for patients. We can design the implants according to the patient size, for example, hip measurements and all. And also the natural learning process, electronic medical record organization, outcome predictions, post-shoulder arthroplasty, rehabilitation, progress monitoring, and for example in the cases of ACL recovery. Coming to the machine learning, AI encompasses a subfield called machine learning. Machine learning can be described as hastening the dimensions to learn and adopt based on algorithms and input data, often surpassing human comprehension. Further subclassifications include supervised, unsupervised, and reinforcement machine learning. Supervised machine learning involves input data being labeled by humans and correcting the computer's mistakes, which is completely under the control of the humans, and we can change the data according to the results we get. And furthermore, when the model is trained to provide accurate ground truth, this allows for reuse of model on new problems, which is referred to as transfer learning. In this way, the developer can avoid having to recreate entire new algorithms for new data sets, therefore saving huge amounts of time and money. Unsupervised machine learning process unlabeled data training data with a known outcome of interest, clustering them as known or unknown. Semi-supervised or reinforcement machine learning learns by exploration of environment based on the reward or punishment from certain actions, And there is a growing body of research in deep reinforcement learning for application of models in computer-assisted orthopedic surgery, reporting capabilities of generating real-world clinical-grade solutions without needing patient data for training. And however, validated and reproducible high-quality tools are awaited. Coming to the deep learning and the neural networks, deep learning is more progressive and comprehensive subcategory of the machine learning, comprising numerous complex layers of algorithm, mirroring the neural networks seen in the brain through artificial neural networks. Deep learning requires human supervision to learn and be modified. An example of deep learning that is being explored in the world of orthopedics is convolutional neural networks, often purposed for imaging analysis and computer vision tasks. For the most part, CNNs, the convolutional neural networks, are made up of these three layers. The first two layers, convolutional and pooling, perform feature extraction, and whereas the third and fully connected layer maps the extracted features into the final output, such as the classification. Used for diagnostic and image recognition, classification and tumor detection, segmentation, and natural language processing. So coming to the natural language processing and electronic medical records. So it describes computer comprehension of language. Functionally, it can scan clinical medical records and make sense of information such as operative notes and radiology reports. And these algorithms have the potential to automate data collection for diagnostic elements, which could directly improve the patient care and augment cohort surveillance. The implications of NLP may include aggregating and analyzing large database abundant in information usually too difficult for manual sorting, and reducing the documentation time. So image recognition and diagnostics. Fracture recognition. The past decade has seen imaging analysis become a considerable focal point among AI research. It should not be forgotten that the performance of CNNs need to be validated both internally and externally before clinical adoption. So while internal validation is proving quite successful, these are the hurdles that make external validation difficult. Example in the case of fracture classification. And one reported issue is relating to different institutions using different labeling systems for radiographs and radiation dosages. So tumor detection, the potential of AI has been shown to extend beyond fracture recognition, and this may prove useful. Machine learning may prove useful for diagnosis for more ambiguous primary bone and soft tissue tumors, ones that are not clearly evident on plain radiographs, and other diagnostic applications. Ranging from developmental abnormalities to soft tissue knee injuries, regarding congenital abnormalities such as hip dysplasia, studies have shown practicalities for radiological measurements in quick and effective manner. AI-assisted diagnosis and classification of OA from radiographs have demonstrated similar accuracy to senior clinicians. And furthermore, CNNs for osteoporosis fracture recognition have been developed to directly evaluate bone mineral density from radiographs. Additionally, the more accurate calculations using the deep learning model for knee alignment may provide the potential for preoperative planning in total knee arthroplasty. However, several limitations such as established ground truths, radiograph quality, alignment, or rotation indicate the variability, and as such, these methods are not yet employed in preoperative planning for total knee arthroplasty. Automated identification of arthroplasty implants using deep learning has been reported to be a useful augmentation revision surgery. enabling accurate planning of the operative technique and necessary extraction equipment. An AI model able to identify processes within milliseconds versus 20 to 30 minutes can have huge implications for patient safety in the intraoperative period, and it can reduce the amount of blood loss and also reduces the surgery time, and the sensitivity up to 94% and specificity of 97% in identifying implant loosening following hip and knee arthroplasty using CNNs have been reported. Of note, the convolutional neural network algorithm outperformed the human counterpart from plain radiographs, illustrating its potential role in preventing serious complications and redistributing clinical time to improve the patient care. And predictive algorithms. Recent literature has showcased the predictive value of AI models to calculate mortality rates, transfusion risk, and hospital stay following elective arthroplasty. It has been reported that the direct learning and machine learning models could predict up to a decade in advance knee and hip osteoarthritis by means of bone texture analysis on the proximal femur and acetabulum and clinical risk factors with acceptable accuracy. Examples in the orthopedic surgery include AI models predicting suitable patients for nerve blocks following anterior cruciate ligament reconstruction. The role of artificial intelligence in surgical training. AI could play a pivotal role in orthopedic surgical training, where a repetition and existence of a training framework are imperative to acquiring competence. Through machine learning and computer vision, AI now has the capacity to gather data and provide meaningful personalized feedback on surgical abilities. The integration of AI systems such as virtual operative assistant into virtual reality and also the augmented reality can help to attain objective critique without depending on typical apprenticeship learning modality. Coming to the rehabilitation and post-operative care, the post-operative phase has been highlighted as a key area of AI interest, and machine learning-based algorithms allow tracking of physiotherapy engagement and exercise participation and alert healthcare professionals if patient milestones are not met. Similarly, the surveillance of patients' vitals, well-being, and complications such as deep vein thrombosis has been documented extensively in the literature. These AI features have been documented to reduce readmission rates following the total knee arthroplasty and total hip arthroplasty. And DL has been touted by multiple studies to be capable of predicting the risk of complications leading to revision surgery using post-operative hip arthroplasty radiographs. The limitations to artificial intelligence in orthopedics. AI is associated with considerable capital cost and financial burden on healthcare systems, potentially impeding its widespread adoption. As with any research being generalized to wider clinical setting, AI models must go through a rigorous process of validation. 6 areas that require attention when appraising CNN models and aim to inform clinical adoption of AI models. The study design, separation of data into partitions for model training and model testing, optimization and final model selection, the performance evaluation, model examination, and reproducible pipeline. So coming to the conclusion and future consideration, the use of artificial intelligence in orthopedics bears the potential to improve patient outcomes and reduce the workload on healthcare professionals. An auspicious future development is the innovative digital twin pertaining to a visual representation of oneself. So this is thought to be at the cornerstone of precision medicine, able to predict diseases, treatment outcomes, and preventive interventions tailored to the individual patient phenotype, even down to the genome level. And in orthopedic surgery, it shows promise in identifying the hip and knee implants, patient-specific implants, and highlighting the implant malposition, and detecting features of loosening and predicting the length of hospital stay, and the costs involved, and also the functional outcomes and the prognostic scores. Yes.
What is the difference between
Virtual reality, it provides image which can be felt real using uh, particular glasses which can be bought. So virtual reality, enhanced version of it. So provides more of like natural. So if you are doing it showcases as it is the surgery doing on a person. So like more detailed 3D imaging of the person. So the data which we give to the artificial intelligence. S- Image registration. No idea, sir. Mm. So, so it can predict the image, sir. It can show the outcome of the and also the functional outcome and also the biomechanics and also the implant status, how long will it can sustain and also the loosening complications. So these were the cases done in Unit 1, sir. This is a 52-year male with a closed proximal third shaft fracture of the right femur. So we opened the fracture at the fracture site and also scooped the material and sent the sample for the biopsy, sir. The report is yet to come. Same, sir. Like there is a lytic lesion. There is a lytic lesion. We have presented this case last week, sir. There is a lytic lesion present in the proximal third shaft fracture. Proximal third shaft fracture. Yes, sir. It's a pathological fracture. And so we open the surgical site and we have sent the sample for biopsy, sir. We have done skull to full skeletal survey, sir. It's a so it's a it looks like a lytic lesion with a simple bone cyst. It's a simple bone cyst, sir. Sir. It's a 52, sir. 52. Yeah.
Last week only bone tumors, how to evaluate a bone tumor. Nikhil has been very dealt with in great detail. What are all the parameters that you look for? You are there?
No, sir. I wasn't there.
That is the issue. Yes, who is the presenter? Nikhil. Nikhil. Yes. Read the X-ray and let us know something about this. You have presented very nicely in the last class. Let us see whether you have gained knowledge with that, and read the X-ray and let us know.
Age 52 years, sir. Of long term femur. Right side. At the site diaphragm region.
Okay.
With the center lytic lesion with sharp border.
Yes.
No mineralization, sir.
Yes. The matrix
Matrix.
is a cortical lesion or a medullary lesion?
Medullary lesion.
Medullary lesion, yes. Periosteal reaction
Geographic
and soft tissue swelling.
soft tissue.
So only X-ray study. We don't have the clinical picture. So if the X-ray is given to a radiologist to report, how will he analyze and think that you are a radiologist and give some opinion? Is it a primary bone tumor or a secondary? That is the first thing that you should think. Your secondaries are the commonest bone tumors. Secondary. So think like that, especially depending on the age. Yes. Is it a bone forming or a bone resorbing? Lytic or sclerotic? Or mixed? Especially, usually in lower limb, around pelvis and in the hip region, especially the trochanteric and neck region, secondaries are common in elderly people because he is in the borderline age. No periosteal reaction, no new bone formation, and the zone of demarcation. That is the most important thing. Ill defined, well defined. Well defined. Poorly defined. There is no sclerotic margin. What type of purely lytic or permeating type of destruction? These are the headings under which you will have to analyze. Okay.
Is there a zone of transition? Is there extension to soft tissue?
No, sir.
Already broken.
No mets.
No, sir.
So probably what is your probable diagnosis? Chandrakant. You are there for the case?
Yes, I was there, sir.
Or during surgery? Macro, what is the findings? What is
Sir,
the
the
material? Gray,
gross grayish red in color, sir.
grayish.
Grayish red in color and
So
soft in consistency.
What was done before surgery? Anything was done?
No, sir. Like we just skilled survey was done, sir.
You subject him to needle biopsy, core biopsy,
No, sir.
throughput needle biopsy.
Surgical biopsy, sir. Just open it and send it for culture.
Why? Why not a biopsy, core biopsy? Minimally invasive bedside procedure. You have to justify the treatment that you are giving.
he has got
Right?
yeah.
Will you be right in doing did the kneeling? What was done with the OT?
Fixations, long PFN was done, sir.
No, why was it done without a biopsy, pre-operative biopsy?
So we considered intraoperative biopsy and just
Intraoperative biopsy.
intraoperative biopsy we have sent, sir.
It is a malignant tumor or a benign
So eventually we are going to fix the bone. So during the procedure, we can take the biopsy and send await for the results.
Any of the treatment does not alter, to stabilize the fracture. While stabilizing it, probably you can make a small incision, take a significant amount of tissue. Okay.
It looks like anything's low grade or high grade, intracompartmental or extracompartmental.
Intracompartmental.
Operative findings ఉంటాయి కదా.
Yes, sir.
Before
Operative
biopsy,
findings ఉంటాయి కదా.
what were the investigations performed?
So we have done head-to-toe examination, skeletal survey, sir. We took the X-rays of skull.
But you
Hip.
have not told
So we have done, but there is no proper findings. I have explained.
does it mean that you have to omit the mentioning the investigations?
No, sir.
Straight away femur fracture PFM అంటే అయిపోయాయి. You are not making the audience think about that. That is what this class is meant for.
Thought provoking knowledge. Update your knowledge. Share the knowledge, gain the knowledge.
We opened the fracture set and we took the sample and sent for biopsy, and also we have sent the sample for culture and sensitivity site, which turns to be negative. And we have fixed it with the long PFN, and we took bone graft to fill the space. We have sir? No, sir. No, no active blood loss. It was minimal.
Incision was extended.
Yes, sir.
The same incision through which the drills were made to the
No, sir. We took there's a separate incision via.
bone grafting was done.
Yes, sir.
Will it help if it is a malignant tumor?
But it will definitely help to fill the space for union, sir.
That's all. Operatively, it looks like benign or malignant or locally malignant.
Looks like benign, sir. There is no active spread, and also there is no it is not highly vascular.
What may be the probable diagnosis? Probably you are there a surgeon. You are a surgeon, you are there with the case. What is your probable diagnosis? Macroscopically, operatively, on table judgment.
He was unable to judge.
We will judge. We have given the chance.
He has already been described
Yes, sir.
past.
నువ్వు చెప్పు చెప్తా మళ్ళీ చెప్తాడు.
Sir, we thought of sending this for multiple myeloma, I thought, sir, but
No other lesion elsewhere.
no, it's not there. So
లేకుండా మల్టిపుల్ మెలన్ ఎట్లా
I thought of sending it for Benz Jones and all.
GCT
Giant cell tumor. It is most commonly around the distal radius దగ్గర ఉండొచ్చు.
More common around wrist.
Radius దగ్గర ఉంటుంది, distal radius.
నాన్ ఆసిఫైడ్ ఫైబ్రోమా నాన్
Distal
ఆసిఫైడ్
vein, proximal tibia, distal and radius.
Radius. It is already comminuted, sir. It is multiparticulated. From the center also. 3 samples. So we cover the entire portion of the, and we fill it in 3 also.
Why not freshen the ends and make contact with the reasonably good quality of bone, shortening the femur?
Shortening it will eliminate discrepancy, and also ఇది కాదు, sir. It's a previous one. The pathological fracture which we discussed last week. So it was a follow-up case for which he has done surgery for other limbs, sir. He came for the follow-up and he fell down and low velocity. It's a
నువ్వు ఆన్సర్ చేసి క్వశ్చన్ ఆన్సర్ చేయట్లా, వేరే దాని గురించి వస్తే పడిపోయాడు అది కాదు కదా. ఐ ఆస్క్డ్ వాట్ ఈస్ ద నేచర్ ఆఫ్ ద ఇంజరీ.
it's a low velocity injury, sir.
Tell that sentence
Sir.
between now and the book.
So you thought it's a pathological fracture, that's all, right?
Sir.
So what the surgery, what did you find here? That's what I want to say. Was the material
It
Right.
was grayish red in color, soft consistency, and also the multiple multi-fragmented bony cortical bone is found.
Was
Sir.
it bloody or not? Blood
It is bloody, sir, grayish red in color.
occupying complete thing or this still distal part or only
No, it
this
is
part?
not. It is localized around 1 to 2 centimeters in and around that fracture site.
At surgery, what did you think? Is the secondaries or something from primaries from outside? At
No, sir,
surgery.
we didn't find any other content involving the
Looks
others.
to be primary tumor, right?
Yes, sir.
You thought.
Involving the bone.
Okay.
One more point, can I add some one more point? So all these cases, when 52 years and all those things, you may be having doubt, you have got in doubt,
Mm.
but it's a molecular study that gives a better diagnosis.
Now what about the pelvis? You had some doubt?
Sir.
And the other one is renal osteodystrophies. Is the patient is
Other parameters were normal, sir. There is
Hyperparathyroidism. That is the condition which you should always keep in mind.
there is no elevated levels of.
Skeletal survey is done, no?
Yes, sir.
Did you find anything?
No, sir. I didn't.
Spine, skull, anything? No, nothing was there. What is this?
And also the serum
Follicle
calcium
is-
levels were normal. No, not elevated.
Lytic lesions without reactive newborn formation. That is one of the differential diagnosis as a last possibility. So you have to look at this angle and then investigate
Sir.
for parathyroids.
Pelvis had some problem. You have seen pelvis. Any light region is there during surgery?
In the X-ray and during the surgery, we have seen lytic lesion in the pelvis, but
Pelvis. You
so
are
it
not
might
sure.
be a
Artifact.
not artifact, maybe gas bubble also. I can't say, but
Show me that if it's there.
it's not here, sir. But I can show the.
Okay, right.
It's completely normal in that.
Chest X-ray,
Everything is normal, sir. In the skull, spine,
so which
and
one?
all.
what is the
we have-
appropriate investigation apart from all the routine skeletal survey?
But-
When you can't make a
PET scan.
diagnosis.
PET scan is ideal.
MRI for diagnosis and PET scan for metastasis.
Yeah.
Apart from that, bone scintigraphy
Mm.
Sir.
and it's clinically not detectable without any symptoms. You can find out the lesions elsewhere which are asymptomatic. Especially in such cases, that is one of the important investigative modalities which can make our diagnosis more clear. Okay.
any doubtful cases.
Any classical tumor is not difficult to diagnose.
Sir.
Something unclassical like this, you have to do all modalities of investigations.
And in these different cases, molecular studies.
Sir.
You have said.
And people are working at Apollo also, I think. So Apollo sir, molecular studies, sir?
Eckhart study there. Markers and different markers, and then the immunochemistry of this can be done.
Hmm.
Can you use AI here?
It can just.
ALN తెలుస్తుంది. What you have. Okay, but
It's tensor. Long PFN. S- uh, yes, sir.
show that post-op X-ray can make out. No, right? It's there here. ఉంది కదా?
Yes, sir.
Right.
It went almost up to the knee joint, sir.
Did you put graft here?
Yes, sir. We have grafting.
Grafting done.
Yes, sir.
It will be useful for this grafting. Suppose,
It helps to fill the gap, sir. But it
but
supports.
primary lesion
If-
still there. We do not know completely excised or not. It may invent that also. No,
Hmm.
it doesn't serve any purpose.
Completely dissolves in no
Yeah.
time.
Okay. Yes, yes. So it has to be done. That's what I said.
Cryotherapy.
Take this from and then wait for this report and then decide what to do. Frozen section is ideal thing. This is at time of surgery. Do a frozen section, find out what exactly the pathology is, then accordingly you can go for this surgery or excision, whatever you want to do it.
So can get the histology report within after.
Yes, yes.
Malignant tumor.
Sir.
That's what everything says. Yeah. Right, right. Okay.
If it is benign, your patient is
Safe.
lucky.
Yes.
You are also lucky. You can fill the entire
With the graft and then leave it.
area
Mm.
with good thick hardcore cancerous graft from the iliac crest and make the fracture unite. Facilitate for
If it's
fracture union.
if it's highly malignant,
Malignant, the treatment is only to stabilize the fracture.
then
No more
wait for that.
At least you can differentiate between a malignant
Yeah.
tumor or a secondary or a primary.
To me, it looked like a primary tumor only, sir. To me, it looked like primary tumor only. The involvement of this complete excavation there. This one, complete is gone. Looks to be primary tumor only. It can be. Can it be Ewing sarcoma?
Age is not relatable.
It doesn't
sir.
matter.
Even
It
it
can
comes
come
in
at any-
second decade, probably.
Any age it can come. It can metaphysal, diaphyseal. It need not be always diaphyseal. It's possible. When some blood cell tumors, round cell tumors.
Did you find out from the patient whether he has some nagging pain before this fracture in the same area?
What a blue
He
round
said
cell.
he was having a pain, sir,
He was having pain.
even before the fracture.
That
Yes.
indicates
Pathology.
that it is a pathological
Patholo-
fracture and not benign.
Mhm.
Malignant tumors will be painful.
Round
Benign
is it?
tumors until they are presenting with a pathological fracture, it will not be painful. Benign tumor.
Sir.
Round blue cell carcinoma is one of the things here. Round blue cell, or Ewing sarcoma, or something from blood cells. All things are this only. The way it is looking very aggressive. This part is gone. Anyway, right.
When was it done? Report is awaited.
Yes, sir.
See computer. Wednesday. Last Wednesday.
Ipsilateral, sir. Because we kept the patient in lateral
Lateral
position.
position. Right.
Yes, sir. No,
How
completely,
you
sir.
are able to
Only one cortex is intact.
interlock the proximal cephalomedullary screw in lateral position? Was it easy?
Yes, but
We applied traction and.
Adera.
maintained it, sir.
we without traction we have done this. No.
No, I mean manual traction,
See-
sir, not through the.
CM was there, no.
Yes, sir, it is
Oh,
there,
then
sir.
what? You use CM. Position is normally what you do for any nailing.
Now, how are you sure that it is going through the center of the neck when you don't have a proper
Is it in lateral position you are saying?
Yes, sir, lateral
what
position.
The traction only, no.
doing in the routine
I'm telling that we applied manual traction for, and then we
No, he is having a doubt saying that was it a lateral position or you put a traction table?
not on the
Traction
traction.
easily can make out.
Now,
Yes,
what
sir.
prevents you from doing it in the routine way
Yes.
on a fracture table?
Routine way you have done, no. Anything else you have done there?
No, sir.
But what?
The additional advantage? In fact, it's a disadvantage.
Is the traction table?
No,
The lateral.
putting the patient on lateral.
No, we have not put that. What I meant to say, we have put on traction table, sir. That's very difficult, is that?
And to take biopsy. from the
Biopsy, huh?
That can be done with the
Yeah.
traction table.
Traction table we have done it
You
is.
can insist laterally.
You live, I know. You live.
No, sir, I was there.
No, no.
There was none. I was
You
the only
know,
one.
then we have traction table for this. Everything we have done. Again, loosen everything.
Now, what prevents you from putting the patient in the routine position, just like a PFN position?
That's what we have done also. Routine position, you have put. No, don't think lateral position.
You were
I
there
think
at that
I was there, sir. I was there.
time? He was there.
He was there, but I don't
I
know.
was there. I was there.
Then why did you say
రాదుగా సింపుల్ లాటల్ రాదు
ఎట్లా screw set?
అదే నువ్వు చూసావు కదరా వీ హ్యాడ్ ఎనీ ప్రాబ్లమ్ నువ్వు ట్రాక్షన్ టేబుల్ ఓన్లీ ఐ పుట్ దెన్
Okay, next.
రైట్
42 years male with intertrochanteric fracture with subtrochanteric extension of the left femur with associated pubic diastasis, sir. It's, less than 2.5 centimeters. Less than 2.5 centimeters.
Stable fracture, unstable fracture.
Rotationally unstable, sir. Vertically stable fracture, sir. Vertical stable fracture. We have done open reduction internal fixation with long
prior to
PFN.
that what have you done? That is come nearer, no?
Yes, sir.
No, then did you apply anything?
Yes, sir. Pubic,
That
pubic binder. Pelvic binder, sir.
pelvic binder for 1 week 10 days, then you have surgery, no?
Yes, sir.
చెప్పు మరి టైం ఉండే ఇట్ హస్ కమ్ నియరర్
Waited for sir.
Yes.
1 week, sir. 1 week. Sir.
1 week, 10 days. 10 days he waited and then it has come nearer. Again, I will go for surgery. ఇది అడాప్ట్ చేస్తూ చెప్తారు
Catheter could be passed easily.
trauma you have produced, I think. Right.
We have done open reduction internal fixation with long PFN for left femur with circlage.
Do you think that this fracture is going to remain? Very high chances of implant failure.
It could be, but
High chances. There is absolutely no medial column.
right. But there is no other go. You have to fix it. Got to fix it.
Probably
First exercise position.
and pulling the
Yeah.
pulling the lesser trochanter and
See,
securing it probably.
it's very tough. But the only thing we have there, you know, to get into approximation all things is really tough thing. At least to put together all the fragments which are there. Yeah.
Pulled it by opening up and then
What else we could have done this?
lesser trochanter.
Oh. We have tried. We have tried. Different. So,
To prevent
Out, right.
implant failure, bone graft
yeah,
to reconstruct the
medial
not
side.
able to pull it, bone graft
But it's
to get
yeah,
continuity of the medial column may help preventing the
right. But it's not a that simple fracture to to tackle. It's quite complicated one. Yes, this is. No. How to classify this? I don't know. Can you classify this fracture? Does it fit in anything? I don't know. Yeah. Okay, right. When do you want to ask him to walk?
ఇది restore any other sensation.
అంతే దగ్గరికి వచ్చి ఎప్పుడు అది బైండర్ వేసి 10 days waited. Then they are doing it.
60 years male with a 2 months old proximal middle third junction shaft fracture of right radius and ulna with thumb drop, sir.
Two months old.
2 months.
What the bump you are seeing here?
It is the abscess, sir.
Abscess.
Initially we have done ultrasound, sir.
Hmm.
They have given for described
Is the swelling, soft cystic, looks like an
It's a
abscess.
soft,
Or
simple
something else.
cystic swelling, sir.
To me, it looked like only the small bursa which is there over that. Abscess was not there. Clinical notes I can say. But you put the needle, nothing was there.
No, sir.
Right?
simple correction.
Hmm. Abscess, but this is what aspiration you have done on that day, no?
Yes.
You put needle.
No, sir.
Mm-hmm. Yeah.
First fracture is open or closed?
Close.
It's a closed fracture, sir.
Treatment done elsewhere.
No. He
Okay.
went, no, yes, sir.
I can't believe on this.
He went for massage, sir. That's natural. Yes, sir.
Mm.
Open reduction internal fixation with 7-hole LCP for right radius and 8-hole LCP for ulna, sir, with bone grafting, sir.
What approach you have gone? The radius?
I was not there, sir. at the
Huh?
surgery. I was not there for the surgery, sir.
No, no.
Raghavendra, sir.
Who was that? But what approach you go?
And
Hey, see this and tell what
Palm,
approach
sir.
you have gone. See the implant and see what. Did we go anterior or posterior?
Sir, anterolateral.
And lateral.
anterior approach.
I mean, dorsal approach, Thompson's only have done. No, can easily make out this area of Thompson.
All proximal third fractures. Why dorsal? Thompson's approach, why?
Why not Vola, Henry's approach? That's what they're asking. Which is easy, which is less bloody. Volar is bloody. Dorsal is not that. Okay, except take care of the pin, that's enough. Well, as volar, it makes difficult. Anterior artery is there, that make it rupture.
This nerve can be easily
Right.
and protected.
grafting was done.
Grafting was done, sir.
Armstrong's approach is a
Post-
short notes,
Yeah.
important short notes.
How to expose the nerve. Do you have seen? We have exposed nerve and shown you. You were there, not there.
Not this.
We have gone to that, shown what is pinned where, how to identify this. 3-4 times we have been showing the same thing. Dorsal approach with the pin exposure, how to do it.
Post-operative movements.
Not came, sir. Not present, sir.
What moments?
No movements.
We have not.
Improve ayinda.
We have not taken, sir. Videos not taken.
Mm.
Post-operative.
Right.
Is it a low radial palsy or high radial palsy?
Low radial, sir. Low radial palsy, sir.
But wrist also,
He is able to do
Extinction.
This extension is done.
Wrist extinction
He
is
is able to
Only
do
thumb.
Only thumb is.
only thumb.
Okay.
Yes, sir.
Will it improve now after surgery?
how did you rule out high radial palsy? Probably recovering little.
Mm.
Wrist drop.
How did you rule out high radial palsy?
The patient is able to do
Wrist extension.
extension. We can rule out.
Recovery.
What is the important test?
So we have to apply patch.
Brachioradial
Hmm.
should be examined.
How to test brachioradials?
Mid. Flexion in mid pronation, sir.
How to do?
No,
Ask him to
demonstrate
flex.
your hand.
switch away.
Demonstrating your hand, how will you test
Right. Oh.
Flexion in mid pronation.
Okay, that's what the prominent thing.
Describe and then do it.
Prominence of the brachioradial is present.
Radial side. Insertion is radial styloid.
Yes, sir. Radial.
Try to flex against resistance. You can make out the
Flex the
prominence
elbow to 90 degrees, keep it in mid forearm and ask the patient to
against
flex the
resistance.
elbow against
Resistance. That's what.
Make a complete description.
Right.
Okay, ఇలా పెట్టి ఇలా అంటే ఎలా సరిపోతుంది?
అంతే they only want to know fracture is there, the plate or
అది అసలు ఆలోచించారా హై రేడియల్ పాల్సియా బికాస్ ది ఫ్రాక్చర్ మే నాట్
Thumb.
బి రిలేటెడ్ టు ద
yes.
nerve lesion. You might have some other
Or
problem proximally.
can this be a tendon injury where extension is gone? Is it possible to have a tendon injury? Which tendon? Thumb drop is there, unable to extend. Which tendon is gone here?
Sir.
Extensor
tendon?
pollicis.
Extensor
Extensor
pollicis
pollicis
and,
long.
Extensor
Extensor
index.
pollicis long.
Extensor pollicis?
Yes, sir.
Longus or brevis?
3, sir.
3.
Abductor.
Longus
and,
only. Which tendon gets involved in collis fracture? And why? Collis fracture, commonest complication is
extensor.
which tendon? Ruptures. And why? Extensor pollicis longus है ज़्यादा.
Yes, sir.
It goes around it lissus tubercle where its acute bend is there. That's commonly gets involved. Similar it can happen here.
Either acute rupture
Or
a
chronic rupture.
due to malunited fracture producing attrition.
Right, right.
Police fracture, malunited police fracture do presented with rupture of the extensor pollicis.
17 years male with closed distal third both bone fracture of left forearm, sir.
But here it's acute.
We have done over open reduction neural fixation with 5-hole DCP for left radius.
Was it a fresh fracture or old fracture?
Fresh fracture.
Yes, sir.
Show the X-ray. So where's the need to put a plate here? You can't treat conservatively.
For radius, it
Oh, yes.
requires-
You can easily put.
There is
You
displacement.
can easily manipulate and put a long arm cast and then leave it. No.
Displacement of the radius present, sir. In lateral blocks.
Still, you can have easily, even if it's not completely, it doesn't matter. One-third contact is enough. No deformity occurs. For such cases, we do only
What are the
No.
displacements here? Can you describe?
displacement. Radius.
Also plating
Okay. Is it displaced?
Can you describe the displacements of the fracture?
Radial displacement of the posterior lateral displacement of the radius, sir.
This one.
Yes, sir.
What are the displacements in AP?
Lateral.
What are the
No, this is in line with this.
In
Right.
a
Adhe, this is lateral.
In the distal fragment is displaced ventrally in
It is always the distal fragment.
Only this
Volar.
fragment.
You don't need to separately say it is the distal fragment. Yes. There is a overriding of the radius. Overriding. That is called Boynet opposition. When it is aligned like this, side to side, it is called Boynet opposition. Okay, like the Boynet of a rifle. Overriding is not easy to reduce. It is angulated.
This is 17 years only.
Good contact.
Skeletal immature. If you put a long arm cast, I think it definitely unites without any deformity. Still, I have done surgery.
That's all. Is there angulation? Is there displacement?
No, no.
angulation,
Right. Just go there.
angulation and displacement.
No rotation?
Alignment is still good. If you just make it straight and put a long arm cast, it definitely unites.
What do you mean by alignment? Can you define alignment of the fragments?
Alignment is right. Both fragments align together. Where
Both cortex are
both
When they are
ends.
in the same longitudinal axis,
aligned.
in a
That's aligned.
alignment.
In one line or aligned.
There is a displacement, there is contact
Counting.
is not complete, there is displacement. When the alignment is changed, it is called angulation.
Okay.
Angulation. In the ATU it is,
Yes.
the convexity is towards the
Medial side.
lateral,
Left over.
the interosseous space is reduced, medially angulated.
Right. What have you done?
By all practical purposes, the both bone fracture or forearm fracture should be treated like intra-articular fracture. There will be no displacement, no angulation, no rotations.
All fractures. Children also.
But not in children.
Not in
That is the exception.
But you have to put it
children. Is a child or not adolescent now? 15 years. 17 years. Can you consider young adolescent? Yes. Not a child.
Can you decide about the rotational malalignment in a plain X-ray? Can you in a plain X-ray?
AB letter.
ఆన్సర్ తెలియకపోతే తెలియదని చెప్పండి అలాగ నిలబడితే లిటిల్ ఇరిటేటింగ్ ఇఫ్ యూ డోంట్ నో ద ఆన్సర్ సే ఇమీడియట్లీ ఐ డోంట్ నో ఎస్ కెన్ ఎనీబడి సే
They will be sleeping.
when the width of the proximal and the distal fragment is exactly same,
No, not display.
that means it is not rotated. If there is a difference in the dimension, in the width of the bone,
That can be.
indicate that it is
Rotation.
Rotation.
rotated. Yes.
Diameter of the distal, diameter of the proximal.
Okay.
39 years male with closed middle third shaft fracture of right femur, sir. We have fixed closed reduction internal fixation with island for right femur, sir.
Why there is angulation here? It has gone to valgus. Yes. No. Well, valgus పోయింది కదా. Okay.
Guide wire has gone
Then,
immediately, that is why there
Oh,
is
right.
opening up of the medial.
అంత ఏజ్ ఇది. Right. You have to make him walk immediately now.
Yes, sir. Yes, sir.
70-year male with entortochondric fracture of the left femur, sir.
ఇదా ఎంటోకాంట్రికా పర్టోకాంట్రికా ఏంది ఇది?
Entortochondric. Yes, sir. Type 2.
Zoom. Different doubt ఉంటే film zoom చేయాలి. Yes. అది కూడా చూపించండి. Why do you want to have full length femur? 70 years old, male patient. Why Why do you want full left femur? One joint above, one joint below. Rule of
To
why?
oh, yeah.
చూసావు కదా?
Angulation of the femur.
Okay, one is angulation, yes.
And also
Bowing.
bowing is present.
Okay, anterolateral bowing. Okay, 1 point, yes.
And also to see the arthritic changes.
Arthritic changes. Okay, 2 points.
Arthritis where is there?
Knee.
Both. Both.
Knee joint.
Okay, okay, accepted.
There is a
Okay,
fracture.
point is up. Okay, next. Third point. 2 points are over. Third point. 70 years లేకుంటే. Is it osteoporotic?
Porotic ఉంటుంది.
Quality of the bone. Sometimes there may be incomplete fractures. There may be incomplete fractures.
Okay, next.
Right, right.
We have done proximal femoral nailing for left femur, sir.
Why not DHS?
Yes, sir, go ahead.
DHS takes long time. This is short time. That's what you want to do. DHS can be done or not? First exercise means?
The lateral cortex is intact. We can.
Yes. Good thing is there, yes.
Hmm.
Lateral wall is good. You can always go for that.
But blood loss is more than ellipsis.
Right.
Now they are, as per other studies, EVO and WLS, they say long-step working length should be more. They are more functional result than.
Tomorrow they'll change some other thing, yeah. They keep on changing.
So
it.
34 ml with closed Galeazzi fracture of the right forearm, sir. I have done open reduction internal fixation with zone hold DCP for
What
the right
about the
radius.
DREJ was stable?
It is disrupted. After surgery, it was stable, sir. We haven't. Reduction was done, sir. It is aligned.
Not palatable. Was it palatable or not?
Sir, it is. Yes, sir, it's not palatable, sir. It is stable.
Position.
Yes, it was checked, sir. It was checked.
What position? Supination, pronation, or mid-tone?
It was supination lobatum last.
You have to see.
No, we have applied the slab also, sir.
Okay. Did you put the K-wire? Suppose you want
No,
to put K-wire.
we can put, sir, but it is in a stable position, so we didn't put any cable.
The best thing is put always in mid-prone.
Sir.
Usually another thing is EFCC. EFCC also is there, capsule is there, ligaments is there. Everything should be taken care. It is previously it is ulnar variance positive or negative? Okay. Ulnar variance positive or negative?
So positive, sir.
Huh?
Positive.
We can't.
Ulnar variance positive in Delhi. Is it stable wrist or unstable wrist?
Unstable.
Huh?
Unstable.
Stable wrist.
Unstable, sir.
ఇంత చెప్పి ఎలిజిబుల్ ఫ్రాక్చర్ అంటేనే అన్స్టేబుల్ ఫ్రాక్చర్. ఇట్ ఇస్ అ ఫ్రాక్చర్ ఆఫ్ రిస్ట్.
Next,
Right.
అన్స్టేబుల్. అన్స్టేబుల్
Next,
అన్నమాట
next.
అందుకే కేవర్ ఇంప్లే
Okay. Right.
అండర్స్టాండ్ ద పాయింట్. ఏం సార్?
correct.
To take the point.
Unstable చెప్పింది మీకు వెనకాల.
40 years male with closed bimalar fracture of left ankle, sir. It's log Hansen supination adduction, sir. Adduction, sir. Yes, sir. Oblique fracture.
Vertical fracture.
Vertical fracture.
This is transverse fracture. The vertical fracture normally shows supination adduction.
Supination adduction, sir.
I can't explain properly. Then.
Open reduction internal fixation with 7-hole semitubular
Posterior
plate.
fragment.
Proceed on the
Any posterior fragment.
No, sir.
No involvement. Only
nothing.
Syndesmos is intact. This is very important thing to be looked at.
What is a bimalar fracture? Pars fracture?
Hot fracture. What the hell?
Spots.
Why I doubt? Is it?
No, sir.
Subperceval pond.
What the cotton fracture?
Trimalar.
You know cotton means?
No, sir. Cords is posterior cortex.
Find out about cotton fracture.
We have done open reduction internal fixation with 7-hole semitubular plate for tibia and
Right.
5-hole LCP for fibula, sir.
Which is fixed first?
Fibula, sir.
You know, huh?
I was
Yeah.
not this. Not this. Pravin, sir.
Right.
Why? Why fibula
For
should be?
attaining the length and stability.
Of the ankle.
Stability. Inca?
Right. Again, huh? Last, right?
It is a 25-year-old male with close 2 weeks old distal third shaft fracture of the right ulnar nightstick fracture. We have fixed it with
Night stick only?
nightstick.
Night stick.
Night కొట్టారా?
Isolated.
చీకట్లో కొట్టారా?
Actually, it is not nightstick, sir. It is not through an assault.
What the type of
He
injury?
fell down, sir. He
Direct
fell down.
injury, indirect injury? Direct or indirect?
Direct, sir. Direct impact was, sir.
మరి నైట్ స్టిక్ అని ఎందుకన్నా?
Night stick, it looks like night.
And how does it get the name on? When we
Usually these such injuries are caused by an assault.
while defense mechanism, it's the first one to get exposed.
To defend
Or
itself,
during-
they
Or during lateral charge. That's
ulna
normal symptom.
is directly exposed. Yes. Okay, it is
Sir.
a fancy name given to that. Doesn't always mean that it should happen with assault only and night only.
Sir. So,
This question has arisen because you have told it is a night stick.
sir, we have done open reduction internal fixation with 6-hole DCP for the right ulnar, sir.
You can't put a plaster and then leave it.
It is displaced, sir, and it's a bicortical,
It becomes straight if you make it traction here.
and also it is
Because
2-week-old and unstable, looks unstable.
suppose this patient,
Unstable అది.
this patient comes
As
to you.
unstable ఎట్లా అంటే there is 80% contact, very minimal angulation, only 5
Even if he writes in this position, what happens?
and in the lateral view,
Nothing.
it is very good. Even if it heals in that position, it is
Nothing
okay.
happens.
There will not be any we don't have the patience to treat or the technical skill to treat it conservatively. One indication is ఆరోగ్యశ్రీ.
That means you
40,000.
hospital
2 weeks old.
right?
చేయలేదు, sir. Margins చేయలేదు. Margins are not sclerosed and fresh.
No, absolutely not necessary. Bone grafting you cannot think of. Yes. There is no combination. It is a fresh fracture. Fresh means not in 3 days. Anything less than 3 weeks is called fresh. Yes.
So you have gone with the DCP.
Yes, sir.
Why not Sherman's plate? What is the difference between DCP versus Sherman's plate?
నాకు తెలుసు.
Sherman లేవా ఇప్పుడు
ఇప్పుడు లేవు, పోయినాయి.
become a
Sherman plate, calculator.
This is also known as bone suturing plate. DCP is a compression at the fracture site.
Sir.
So there is a bone suturing. Everything is good. Approach. Henry or
మళ్ళీ షర్మన్ అంటే ఎగ్గర్స్ ఏంటి అని అడగాల్సి
మరి
వస్తుంది.
వెనబుల్ అడగాలి.
Sir. It is given between the flexor carpi ulnaris and extensor carpi in the foreign. No, sir, it's in the lateral. Medial లో ఇచ్చాము.
Right.
So 40 of him.
1/3 tubular plate is ideal.
Sir.
1/3 tubular. It is a thin plate unlike DCP and it has got a better stability than regular because it is a tubular bone in the distal 1/3. Yes.
and another simple one. The whole of the radius can be exposed in anterior embryos approach. The whole of the ulna can be exposed in posterior or Thompson. These are the basic principles. Except at middle third. Except at middle third fracture, both can be exposed to the posterior.
Yes.
Because at the level of that, it is both are subcutaneous.
Can you fix both bones forearm with a single incision?
Single incision, both bones forearm, single incision.
Only
We have to
or
expose
women
separately.
should be on it. They can do it. Otherwise, no, don't do it.
Should not be done.
Mechanics, yes,
High chances of cross
yes,
union.
trust. But
Okay.
old people, when the muscles are lax and then skin is lax, and need to do it. That instant, it's not always done.
Whereas Montajar fracture dislocation, that is different. That is different. Geliza is different. All of
So for implant removal, okay.
Okay.
40.
Right, next.
Indication for implant removal. That's the
Mm,
only point
so
you should say.
Patient came herself, sir. I just want to get it removed.
Complication.
No complications, sir.
No
Nothing.
implant loosening.
No
pain,
implant loosening, no pain, no discharge, no sinus formation, no signs of infection.
No infection. Yes.
Movements normal, everything normal.
Everything is normal, sir. But osteoporotic, a little bit of flexion is
Flexion is full.
no, sir.
ఎంత
Flexion is not, but she didn't came with that complaint. She just want to get it removed.
Complaint లేకపోతే knee flexion ఎంత చెప్పవా?
With stiffness, without stiffness.
What was the flexion?
It was around 90, 100 degrees or so. 100 degrees or so, sir. అంతా రాలేదు, sir.
Okay, okay.
Why?
So we have done implant removal for this case, sir.
What do you advise in this?
Physiotherapy, post-op.
The whole tendon is
Supplementation, calcium supplementation by D3 and non
how much time it takes to fill up this hole? Till that time,
3 months to 6 months, sir.
6 months, yes. Till that time, I have to be very careful. What they know in a high velocity.
You see the cortex under the plate is so thin. That is very, very important observation to be made. You should protect the ligament. There should not be any angular force. Otherwise, they are likely to have it. See, the cortex is paper thin, lateral cortex.
Every chance in the
Under
brain.
the plate, the cortex is very thin.
Okay.
Okay.
So the stress shielding effects are more with the DCP compared with the HCDCP. Or with the
ఇది లాస్ట్ వీక్ ప్రజెంట్ చేశారు కదా
Yes, sir.
Yes, sir.
ఫర్ మేనేజ్మెంట్ పర్పస్.
Yes, sir. 70 years male with closed middle third shaft fracture. Internal fixation with 9-hole DCP for radius and 9-hole DCP for
So what do you think you have done now? Show me the first X-ray. So this what is this you have discussed about this?
synostosis, sir.
Right?
Synostosis.
Synostosis or cross union.
Yes, sir.
Cross union. Is that same?
Synostosis along with
Synostosis is congenital.
Post traumatic or
Post-traumatic.
Post-traumatic.
Post-traumatics.
Yes. So what is the problem?
synostosis is a congenital or post-traumatic?
so post-traumatic.
No, అడిగిన question. Synostosis means post-traumatic or congenital?
Congenital synostosis.
Refers to congenital or post-traumatic.
Both.
Common applied only for congenital man. Cross union only for post-traumatic. Right.
Next.
So what was done? Tell me. You have seen
9-hole DCP for radius and 9-hole
Okay,
DCP
okay.
for ulna with
Okay,
we have broken the synostosis.
you were there for surgery.
Yes, sir.
Oh, చెప్పమా ఏం చేశారు?
We have broken the synostosis, sir.
Oh, yes. Are you able to do it completely or not?
No, sir. We
Okay.
are unable to make complete.
But what are the dangers of doing all these things here? Did you expose the nerve or not?
Yes, sir.
But all things are important in this.
Pin now exposed and secured, sir.
Completely expose and then see what it is. And then they have gone through the till here. You could have at least some partial movement you could gain, not complete.
Yes.
Rotations are not so complete. Partial you could gain. Otherwise, the alignment is good. Every chance it may again go into cross union.
Crossing.
Left or right?
Sir. Right, sir. Right, sir. Right, sir.
Dominant, non-dominant.
Dominant, sir.
So after surgery there is rotations, peroperative rotations are good.
No, sir. Not complete rotation, sir.
Position of the forearm,
What between the
Mid-prone, sir.
functional position.
But what about the plate? Did you bend the plate? There's a bump there. You only important is there. So the first X-ray. You want to go. This is a fracture which is middle one already united.
Crossing
Bad
hands.
position. So you'll have to cut off this and then contour the plate for this so that it will fit exactly. That's what you have done. No,
No, sir.
చెప్పండి కేమి
What are the parameters? Medullary acid,
Normal, sir. Normal, sir.
అవన్నీ normal.
Normal ఉండేవి.
సర్లేవయ్యా.
bones you can dance.
చెప్పాలి సార్ రైట్ రైట్
62-year female with fracture neck
Okay,
of
good.
the left femur, sir. It's transcervical fracture. So we have done cemented bipolar hemiarthroplasty for the left hip.
Hmm.
The vertical and horizontal offset appears normal, sir.
That's true, right.
Equally on both sides. 56-year female with intertrochanteric fracture of the left femur.
PFN done?
Yes.
Yes. Okay. Is it
65
fresh,
years female with closed proximal third shaft fracture of right tibia,
is it
sir.
a fresh one or old one?
So it's a fresh one, sir.
Huh?
Fresh fractures. And 2 years follow-up case of proximal third shaft fracture of left tibia, sir, with implant in situ.
Hmm.
And previously, surgery, external fixator was done to the right tibia, sir, 2 years back.
Mhm.
And now the mode of injury is road traffic accident, sir.
Okay.
And we have done open reduction fixation with 10-hole LCP, T buttress plate for tibia with bone grafting, sir.
Yes.
Intertrochanteric fracture of Malay 60 years male with 3 months old intertrochanteric fracture of right femur, sir.
3 months.
With 3 months, sir. With Z effect, sir. Z effects.
What is the difference between Z effect and reverse Z effect? Which is good? Z effect is good, or reverse Z effect is good, or which is bad?
Proximal
both
reverse
are
Z
bad.
effects.
Right.
Both are bad. What is the difference?
But was it done here only? When was it done?
Here only, sir.
Where?
Here only, sir. You know,
So it has come for removal, is it?
no,
It's
sir.
coming out.
No, sir.
You tell
fixed,
this
sir.
properly. Surgery done 3 months ago.
Yes, sir.
Patient has come with this effect where the patient is
Yes,
able to walk.
Patient early weight bearing was
No, the patient able to walk or not?
able to walk, sir,
Without pain.
with pain, sir.
He's worried about this area which is abutting out. He didn't.
No, sir.
Argale?
Healing, sir. It was
No,
healing, sir.
He's worried about this which is a painful area. That's what? Okay, what have you done? Put inside.
No, sir. We tried to fix on the same screw, sir, but it was more of anterior,
Loose.
sir.
Loose.
Sir,
It
screws
was
was
loose or
more of anterior. It was loose, sir.
So you have changed that?
We have changed the positions.
Screw appears to have been bent. Proximal screw there. See, there is the gap between the two screws is not parallel. The proximal screw appears to have been bent.
Okay,
Outside
yeah.
the bone. Yes. Outside the bone. In the same track.
No, sir. We have changed the track, sir. We have changed the tracks.
Same track. Change it.
Back again. If it is in the same track.
Or is it?
We have changed it.
loose while.
It was fitting now.
Yes, sir, it was
You got it more inside.
It didn't get pulled back, it got callus formation inside.
Okay.
So if it is in the subchondral bone in the head, probably it may have a reasonably good
Good.
purchase.
Yes.
Right.
Sometimes you have to remove the fractional screw.
Both here again put it. Just they removed one more put there. Put.
Yes, sir, both remove. Proximal remove. 6.4.
Good morning, sir. These are the cases done in Unit 3. 52-year male with closed middle third shaft fracture of left clavicle. Allman's classification group 1, sir. Mid third shaft fracture and is completely displaced.
Old
We
one
ha-
or new one? Old fracture?
No, sir, new one only. We have done open reduction internal fixation with 6-old clavicular plate with interfragmentary screw.
Anteposterior or superior inferior?
Sir?
Where's the plate fixed? Anteposterior or
Yes, sir.
superior inferior?
Anteroposterior.
Ida.
Ante superior incision was given, sir.
But from above down you have put or from anteposterior which is commonly done this only from above down, that's superior inferior, not anteposterior. Different ways to put plate, either anteposterior or from superior surface.
27 years male with 7 months old post-op status closed comminuted proximal third fracture of left leg. This was the first at the time of presentation, sir. This is the pre-op X-ray. Closed comminuted proximal tibial fracture. For this we have done MIPO-plating, sir, for left tibia. Patient didn't came for follow-up, sir, at 6 weeks. He directly came after 3 months, sir. This is the 3-month status. That time he started walking without advice, sir. Here there is no signs of callus and plate was bending, sir, slightly here. Then we advised teriparatide injection and stent immobilization. This is the after 2 months X-ray, sir. Here non-union still persists, sir. Here we plan for the bone grafting. Once we open the fracture site, there is we observe the pus inside, sir. So we remove the plate and thorough wound was given. Then we temporarily stabilize the fracture with external fixation. After 6 months, we removed the external fixation, apply slab below knee slab for 2 weeks.
Right.
After that, we have done open reduction, internal fixation with nailing, and 8-hole Helix plate with bone grafting.
So you have to wait.
How are you sure that it is not going to get infected again? However thoroughly you deprive,
Yes, we put
likely that the infection is
Right.
here we put antibiotic coated bone cement. So any remnant of infection, it will.
Okay.
when did you put the
Before before X6 application, we put antibiotic coated bone cement. Then we apply the external fixation.
But muscle.
he came with a bent plate.
Yes, sir.
Was there any infection at the primary
No infections and
First X-ray. First X-ray.
yes, sir.
This much gap is there. You think it will unite that time?
This was the immediate post-op
I
X-ray,
know.
sir.
But this thought it will unite or not? The combination here and here. This gap is there. It's not properly reduced. Every chance, no need only.
Mipo plating, sir. Not open.
Yes.
Yes, sir.
This is what combination. Going to complication. Yes. Yeah.
Okay, probably when you think that when you think that there is a infection at the fracture site,
Yes, sir.
probably antibiotic impregnated nail as a first procedure will eradicate the infection to a great extent. Very, very low chances of again reinfection. Antibiotic, a thin nail
Okay.
with antibiotic coating, maybe even rush nail, is going to make the chances of getting infected again a remote chance.
Okay.
That is ideal. Otherwise, still it is a high possibility that it may get
Infection.
infected again. It can go all along the entire length of the medullary canal, nail.
Yes.
Whereas putting bone graft at the fracture site only, it may not be carried throughout the medullary canal. We don't know whether the medullary infection is there or not,
Yes.
because there are screw holes, not screw holes, that X-fix holes are
X
there.
holes.
So ideal would be antibiotic impregnated nail
Okay.
for 6 weeks, and then remove the nail and do the grafting and nailing
Okay.
or plating, whatever is appropriate. Okay. Next, quickly.
Good morning, sir. These are cases done in Unit 2. 32-year-old male with closed tibial plateau fracture of left leg, sir. Yes. 32. Tibial tuberosity.
Is it an avulsion fracture?
Tuberosity avulsion.
Avulsion.
Not complete.
The margins are rounded and sclerotic. So if it is a
Yes,
fresh
mild
fracture, the margins will be irregular. And if it avulses the whole tibial tubercle. And it is at the site of the insertion of the ligamentum patella.
Chest mark.
Now the ununited ossicles are there. These ossicles will not unite at all. That becomes a OSD, ossicle-striated disease. That, right? Okay. Yeah.
Why not an above-knee cast?
Yeah, that's what is conservative.
There is a very good contact, is there, no angulation. You can make a little manipulation and
Yes.
grab
You
on the medial cartilage.
put a straight one
Lateral
plus
no angulation.
long leg cast is enough.
Metaphyseal bone, highly vascular, young man.
All the 3 columns were involved, sir.
So, what
And
3
still-
columns are involved here? This is fracture line which is here, right?
No, how is the
Columns.
contour. Do you find any discontinuity
No.
there?
In CT it was there.
Huh?
CT.
it is.
No, CT would be sir.
No. Is it required CT?
Intra-articular extension was there.
Articular margin is absolutely normal. Even if there is an intra-articular extension, it is going to
No need, yes.
heal in anatomical position.
So what have you done?
Platings.
Plating. Because it's a varagustri case. Right.
Open reduction and internal fixation with dual plating for FTB as well.
If it is my leg, I would like to have a
Very
long
good,
leg.
very good. You have to teach them first before you ask questions. She knows, okay. How many columns are there?
3 columns.
3 columns. What are they?
Posterior, medial and laterals.
Posterior.
Medial, lateral.
Okay. Identify here which constitutes posterior, which is medial. Nowadays, the Schatzker classification is not very practical. That's why column concept. So that you stabilize the columns. Okay. Ante kada?
You have to justify why it was fixed.
It's the medial.
Be wrong. You have to justify. Plain X-ray.
The fracture was extending into the.
Depression. Articular contour is absolutely normal. Only a 5 degrees of angulation.
What type of fracture it is?
Schatzker type 6.
Okay, but generally it's a metaphyseal, diaphyseal, or
Metadiaphyseal.
it's an
Metaphyseal.
intra-articular fracture.
Yes.
What is the basic principle of treatment of intra-articular fracture? What is the basic principle?
We reconstruct the intra-articular surface.
Yeah, important. So you have to restore
Restore
joint
joints.
congruency. Second, what else you want to achieve? What is the function of a joint?
Range of motion.
It makes you walk, isn't it? Makes you move. So mobility. You must restore movements of the joint as early as possible. Why is that? Why do you want to
Joint.
move the joint?
We prevent the joint fit.
See, previously we used to feel that you can immobilize joint forever, put them plasters for months together, and they come back with,
Joint stiffness.
and the most important part is articular cartilage. It does not have blood supply.
Blood supplies.
Unless you move the joint,
It won't
it
be
does
blood
not. So if you put them in a plaster, specially damaged articular cartilage, it will degenerate. So the idea is to mobilize them early. Okay. So you have to see whether if it is anatomical reduction, if you can mobilize early, you don't have to fix it. Can you achieve those 2 goals here? Show me the CT scan. Yeah. And broadly, what do you see on CT? You see the displacement, and is there any widening of the metaphysis? Any widening?
No, sir. No widening, sir.
No widening. It is increased. There's a leading question. You should. Oh, can you see there? There is a displacement there, and this is widened. If you draw a line from there, it's widened, and this fragment probably not displaced, but it's widened. There is no depression, but there is widening, and there's so many. How many columns are involved?
3 columns are involved.
3 columns. As a principle, if 3 columns are involved, it's unstable fracture. You cannot mobilize it without fixation. That's what Dr. Anjaneyulu is asking. Why can't you treat in plaster? Because it's a 3-column unstable fracture with a displacement, widening of the. If we leave it like that, what happens? The widening will increase. So that's the justification. And so many pieces are there, maybe. That's intercondylar region, but But on the whole, as I said, there is no significant depression. Maybe little widening also, not very significant, but little. Okay. So what was done?
We have done open reduction and internal fixation with dual platings.
Okay. Anybody can come? Sridhar? We'll ask seniors to comment. How would you criticize this? This is a loose piece, this one?
So,
Or radiological appearance? Huh? Loose? This is a loose. Should have fixed that one. Don't you think, Sridhar? Yes, sir. That's this one is. You can see the widening. I think that may be the piece which is. Have to be careful. How old is the patient? 34.
32-year-olds.
May have to put a screw there. Okay. You happy with it? Were you there?
Yes.
How is the wound? When was it done?
1 week back.
Okay. So what is the most common complication of these fractures? Vivek? Immediate complication. Was it fixed immediately or after how many days?
After 1 week.
1 week, okay. Why 1 week delay?
There was a wound, sir.
Yeah.
There was
So what is the common complication?
infection.
Wound breakdown, skin necrosis, and infection. Common complication. Wound is okay now?
Yes.
And wound pictures, clinical pictures are also. See, interesting, there is no point in discussing 10 cases. Discuss one case and properly. And every time next time if anything like that, just clinical pictures, pre-op, post-op, 2 minutes you should be able to finish. Anything? Compartment syndrome as well, that's important. Blisters were there?
No, sir.
No blisters. All right. Looks good. See the joint surface restored in both views, here and here. What is the normal slope of tibial slope?
7 degrees, 5 to 7 degrees.
Oh, more than that. Vivek, you've seen TKRs, assisted TKRs. What is the normal posterior slope of the tibia? 7 degrees, 5 to 7. Okay. Okay, next.
35-year male, 1 week old, closed, both bone soft fracture of right leg, sir.
Okay.
We have done close reduction, internal fixation with internal locking nail of right tibia.
Okay. Next.
56 years male, sir. Closed middle third shaft fracture of right tibia and proximal third shaft.
This one before you. Yeah, gone. This one. Okay, gone.
Fracture. Proximal third shaft fracture of fibula, sir.
No clinical picture.
Closed.
Close, but even in pictures will give so much of information. 56. So go back. Just looking at X-ray, can you tell what is the mode of injury? What could be the mode of injury?
Twisted injuries.
So
Fall
it's,
from height and twisted.
so direct or indirect?
Direct injuries.
Direct injury.
Fall from.
Say, twisting injury, indirect. So this injury will be more significant. Okay.
So we have done closed reduction, internal fixation.
Can you
with
treat this
interlocking.
plaster? Go back. Can you treat it?
Can
You can.
spiral.
Yeah, it's just oblique, spiral fracture, unstable fracture. If you can achieve a stable reduction by closed means, you can treat. But okay, good. Nowadays, I think people also won't accept a tibial fracture if it is not treated, not mobilized rather. Okay, plasters are coming down day by day. Okay.
60 years. Polar screws. Polar screw, sir. For polar screw.
Polar screw.
Two. Yes, sir. While doing. Yes, sir. More lateralization of the.
That looks good. Good reduction.
Due to a faulty entry point is the cause. Faulty entry point. So how to choose the correct entry point?
How do you choose the correct entry point which goes through the center of the medullary canal in the proximal fragment? Huh?
Pre-op.
తెలుసా లేదా తెలియకపోతే ఎందుకు గెస్ వర్క్ ఎనీబడి సో బిఫోర్ పుట్టింగ్ ద గైడ్ వైర్ అండ్ మేకింగ్ an opening with an awl, keep the C-arm ready with you, and then after opening the joint for an entry point, not opening the joint, for the entry point when you have opened up, put the limb in such a rotation that the vertical portion of the lateral condyle of the tibia exactly bisects the head of the fibula along the styloid process. With the limb in this particular rotational position, identify the medial margin of the lateral tibial spine and keep a guide wire along that with the limb in extension, with the knee in extension. And then make a mark with a cautery on the line with the guide wire. Guide wire not introducing through the limb, on the over the limb. So that particular point, the medial margin of the lateral tibial spine corresponds exactly to the center of the medullary canal of the tibia, so that this complication can be avoided. It's very clearly written in Campbell. Yeah. Okay.
Why do you want to keep that screw? Taking the polar screw out. Why it was not taken out? You would have avoided all this discussion. You should take it out. Technically, ideally, you should take it out. But anyway, we could have seen the hole.
So now the present concept is intercondylar remnants, medial and lateral intercondylar remnants. Exactly center point is the ideal point. That is an
Can you
ideal
explain
point.
clearly for the benefit? Monitor.
Yeah.
So tell them in
Yeah.
two simple words.
Yes, sir. So we have got a lateral intercondylar remnants, medial intercondylar remnants. Exactly the center point is the entry point, and you should be matched both in AP and lateral views. The nail should be in the center of the medullary canal, both in AP and lateral views. And the tibia is a triangular subcutaneous bone. When you pass the nail, you should have a good reduction. Just tap. Don't do it. It never comes. It splinters. So you should be very, very careful. 1+1. Yes, sir. No. That is anatomical. That is a more anatomical landmark. Yeah, otherwise you have to check for the AP, bisect, and all those things. That is more. Yeah, that is more radiation. This is more anatomical.
But generally, what happens is it holds well most of these conditions. So you check the tibia, the medullary canal roughly where it comes out, both in AP and lateral, and keep this 10 degrees angulation. 10 to 11 degrees.
And ideally to choose a cherry spot. Once open the ligament, the cherry spot which is there, that is ideal entry point, right in the center of the thoracic. Cherry spot you can make out easily. The gushers which you have seen there, hexagonal, that's the cherry spot. That's ideal.
And do you go through the tendon or side of the tendon?
Side of the tendon.
Side of. Never go. We used to go in the middle of the tendon, but I think tendon injury, tendon irritation, post-op complications are more. Dr. Anjanil, go on the medial side only, or through the tendon.
I split the tendon.
Tendon, okay. Huh?
I split it. And the nail should not be proud
Yeah, that's I think. Otherwise, it will cause bursitis. No. But you can do medial side as well. Medial side. Okay. But that's a good example. You go back of using a. Everybody knows what is it. Go and read today. Especially for the proximal part of the fractures, it is more useful.
60 years female, sir. Intertrochanteric fracture of the left femur.
Okay.
Type 2. Broadening. I have done closed reduction internal fixation with proximal femoral line.
I think you stop for these ones. Probably we should do long nail. Long nails. Long nails should do. Short nails should be discouraged unless it's a very stable one. Okay.
40 years male, sir. Closed distal radius fracture of with ulnar styloid fracture of left forearm, sir. It's a volar Barton, sir.
What classification would you use? But
Frigman's classification.
what type?
Type 8, sir.
I'm sure everybody knows Frickman classification only theoretically. Probably practically may not help much, but it's a Olar Barton. Huh? Olar Barton with combination. Distal radius also columns. Okay.
So we have done open reduction and internal fixation with plating for left radius, sir.
Okay, looks good. Maybe there is central depression, but I think should be fine. Okay. Oh, only one screw is there, isn't it? Yeah,
Yes.
probably. This one you could have passed one more screw that way. One screw is not good enough. And this you should have used fully cancellous, fully threaded cancellous. It's partially threaded. But anyway, the whole idea is buttressing. These two screws are more important than this one. Okay, good.
Yes. Yes.
Done?
Done.
Okay, very good. Unit 1, how many cases are pending? Who is it? Nobody in it. 5. Unit 2?
2, sir.
3?